So some of you may have had a colonoscopy, but for those of you who haven't, I'll kind of run you through it. So you come into the endoscopy lab, and you put on a gown, and you lie in a gurney, and you get wheeled into a dark room, and you begin the process of conscious sedation, intravenous. And suddenly you realize you have a question for me. Now this question has some pejorative value to it, so you've refrained from asking it. But the drugs are taking effect, you got a little buzz on them. It's time for you to ask this question that's been in your mind for a while. Now, I've heard this question a lot, and I'm always interested in the first three words. It appears that you think that one of us is not here of their own volition. Maybe I have had this overriding, compelling thought to be here. And I'm thinking, what are you doing here? You're in a dark room with a stranger who you think has a compulsion to put a plastic tube in your rectum. Now my answer to this is that I'm a complicated person. I work in a complex subspecialty. We have 7 organs we study. Each has their own set of disease processes and multiple treatments for them. It's probably the most single complicated, most subspecialty in internal medicine. So you've confused me with somebody, I think. I think you've confused me with a colorectal surgeon, a proctologist. In any event, I wonder how I got into this position. How did somebody take a thoughtful, well-rounded individual like myself and turn him into a caricature, a unidimensional caricature of a doctor? And for the answer to this question, I go back a few years, and I have to blame these people. This group of subspecialists from 7 different institutions studied a group of patients from 1980 to 1990, 7 academic centers, over 1,400 patients, and they took these people, these 1,400 people, were people who on their first colonoscopy were found to have 1 or more adenomous polyps. And they surveyed them colonoscopically, some at 1, all at 3 years, and most at 6 years. And then they compared them to historical databases of people who had polyps, for example, in the Mayo Clinic, surveyed by barium enema. And that the middle dotted line is for people who had that was a computer-generated group. But as you can see, at the end of this 10-year period, there was a significant drop in the rate of colon cancer amongst this group, such that compared to the historical groups, there was almost a 90% decline in the rate of colon cancer. Now that study came out in December of 1993. It's hard to do all this work and arrive at a 2-part paper in the New England Journal of Medicine. So they went back and did another study. 23 years later, they looked at these people, and they also added another line to that chart, and that is the people at the beginning of the colon polyp study who were discarded because they didn't have polyps. And I think the important thing to notice from this is the real value of having a negative colonoscopy on your first exam. These people rarely got colon cancers. The folks that got colon cancers in the group that had been studied in the colon polyp study, weren't under the usual guidelines that we employ today. because they didn't follow them out at the frequencies that we do. But nonetheless, there is a problem, which I'll get to in a minute, with our ability to prevent colon cancer. This slide just shows, and I think for those of you without opera glasses, the incidence in our country and others of colon cancer over the last 15 years. And to just break it down a little bit, the incidence is in blue and the mortality is in red. And anything to the left of the center line is good. It turns out that our country has been most successful at preventing colon cancer, with a decline in colon cancer rates over a 10-year span of 3+ % per year, far in excess of most other countries. As you can see, in those blue lines, there are very few other countries that even have incidents that have declined. And in our country, that number would be higher if we had more people that were screened, and also the underlying number of colon cancers in the unscreened population is going up in this country, as recent studies have shown in the pre-screening population. Now, it hasn't been a perfect situation because we miss colon cancers in some way. We have people who, during screening intervals, come up with colon cancer. And it's a little bit surprising if you look at these pictures, because colon cancers occur 50% on the left and 50% on the right side of the colon. And if you look at these pictures, you would think, given the size of the haustral folds on the left picture and the circuitous nature of the sigmoid colon and diverticular involvement, that you'd be much more likely to miss polyps on the left side of the colon. So what is going on here? Well, over the last decade or so, we've come to the realization that although we have focused since the National Polyp Study on adenomatous polyp, that there is a third type of polyp. And this is the sessile serrated polyp. So hypoplastic polyps, we all know, don't have any malignancy potential. And adenomatous polyps grow over the span of anywhere from 7 to 16 years into cancer. And the sessile serrated polyps have a different pathology altogether. These polyps tend to develop on the right side of the colon. They're an estimated cause of 20 to 30% of colon cancers. They have a different genetic pathway to cancer that is faster than adenomatous polyps. And when people look at interval colon cancers that develop on the right side, they find that that genetic pathway is what is present in those cancers. In fact, there have been case reports of people leaving these polyps in colons and coming back a year later and finding cancer. These are responsible for a large percentage of our interval cancers. Shifting gears a little bit, we'll talk a little bit about risk factors for colon cancer, and there are a variety of environmental risk factors, and I've listed the ones that I'm aware of. Interestingly, this isn't an environmental factor, but height is a risk factor for colon cancer. The top quintile of people in height have about a 30% higher risk of colon cancer than the lowest quintile. This was actually demonstrated in the National Polyp Study way back when. There are syndromes that are associated with high risk, and I'm not going to dwell on most of these, but I would focus on Lynch syndrome because you'll find this in the context of a general medicine practice. Lynch syndrome is responsible predominantly for right-sided colon cancer development. Like the serrated polyp pathway, has a rapid progression to cancer. People who are identified with Lynch syndrome are told to have colonoscopies every 1 to 2 years. And like the serrated polyp pathway, these folks have this is a germline mutation that results in a mutation in the DNA mismatch repair genes, those genes that are responsible for the proteins that repair base mismatches when DNA replicates. It turns out that the serrated polyp in that pathway also has, as part of that cancer development, DNA mismatch repair mutations. Now, I would like to just mention that you'll run into people with family histories that suggest Lynch syndrome, and I think the red flag that you have to look at whenever you have somebody describe a family history and cancer is someone diagnosed under the age of 50. Lynch syndrome involves 2 generations and 3 or more relatives within the family history with colon, small bowel, endometrial, ureter, or renal pelvis cancer. And this is called the Amsterdam criteria. And there are other cancers that have also been invoked, but have not yet been included amongst those. Now, moving along to conventional screening modalities, apart from colonoscopy and still accepted as screening modalities, are fecal immunochemical testing for hemoglobin, which has a very good success rate for detecting colon cancer, and a pretty good success rate for advanced adenoma. Fecal blood testing has been shown to have anywhere from a 20 to 30% risk reduction in colon cancer as a method of preventing cancer. Flexible sigmoidoscopies, are less effective maybe than they were years ago because colon cancers have migrated to the right side of the colon for reasons that we don't understand. So we have that 50-50 mix in right and left-sided colons. Double contrast barium enemas, although they're still allowed, they've never actually been shown to prevent colon cancer in any large studies. Some of the newer modalities that you've probably heard about, maybe had patients that have undergone, include CT colonography or virtual colonoscopy is the layman's term for it. And it involves an extensive bowel preparation generally, but although there are other, there's less prep, and there are techniques now that are available that involve little prep. It's non-invasive except for ionizing radiation, and it also allows the identification of non-luminal disease because of the CT scan. The disadvantages to CT colonography are that it is less sensitive for small polyps. Once again, the ionizing radiation. It is the equivalent of having a barium enema, and there are overlapping costs because radiologists tend to find things like the 5mm hypodense mass that needs to be re-imaged again in a few months, irrespective of the fact that it's a cyst, like so many of these are. CT colonography has kind of gone by the wayside. Borland-Groover Clinic bought a CT scanner for this purpose years ago, and we don't use it very much because it's not paid for. Medicare doesn't like it, and the insurers have followed suit. It's expensive, and there are overlapping costs. But it is a good test. It is a good test. Here's a study of 311 patients who underwent same-day CT and optical colonoscopy, and as you can see, did very well with finding polyps as well as cancer. Capsule colonoscopy is the newest modality from the technical standpoint of actually visualizing the colon. Its advantages: there's no sedation, it's non-invasive, really nothing in the way of complications. It involves a rigorous prep because with colonoscopy you can clean the colon out as you're doing the exam. Not so here. It's less sensitive. sometimes the capsule runs out of time before it gets, the light goes off before it gets to the end of the colon. And there are layered costs involved in any test that's just diagnostic. And as well, it's not as sensitive as, let's say, virtual colonoscopy. This is one study of high-risk patients, reasonable number. The numbers for colon cancer sensitivity I've seen in other studies can be higher than this in the 80 percentile range. Cologuard, of course, is the newest, well-publicized technology to be applied to colon cancer screening. And it's advertised as a DNA test. It's more than that. It's a DNA and a fecal immunochemical test. So both tests are applied to the stool in Cologuard. And the genetic defects that are tested for include at least one defect that is found in the serrated polyp pathway. Here's the largest study that I know of comparing colonoscopy to Cologuard. 10,000 patients. The colonoscopy numbers are as noted, but the Cologuard numbers are split up so that you can see what percentage of tests that were positive could be attributed to the DNA testing versus the stool heme testing. And as you can see, Cologuard is a very good test, 8% failure rate for finding colon cancer. It's quite a bit less sensitive for advanced polyps, and these include polyps that are 1 centimeter or larger in size or have villus. That's a high-risk histology. As far as serrated polyps are concerned, it's been determined that Cologuard is better than FIT at finding serrated polyps, but it still has about a 40% miss rate for 1 centimeter serrated adenomas, which are large and high risk. So, the interesting point that I'd like to make about this is the largest number of patients in this group who were detected with cancer of the Cologuard group were positive by stool blood testing. So the Cologuard, as I mentioned, the Cologuard miss rate is 8%, but 80% of cancers detected with Cologuard were due to the FIT portion. DNA testing was about 42% as sensitive as colonoscopy for detecting advanced adenomas, and it was about 17% as sensitive for detecting non-advanced adenomas. Price always enters into it, and this is the cost as the CMS payments for these tests. Capsule endoscopy, I can't find that they pay for that at all. Screening colonoscopies, Medicare payment is on the order of about $550. As you all may know, the private insurers pay more, and the national average for the cost of a colonoscopy is somewhere a little bit above $1,000. The FIT test is remarkably inexpensive considering how well it performs. It has about a 2 to 5% false positive rate compared to 10% for Cologuard. And factoring into the cost of these is also how often they need to be done. Colonoscopy for the average risk patient is going to be once every decade. Cologuard is recommended every 3 years. CT colonography is recommended, if it can be done at all, every 5. So how do we risk stratify? The average risk patient is someone without any family history, and their screening begins at age 50, at age 45 for African Americans. We'll get into the various the next slide will tell you a little bit about what modalities are accepted and what groups suggest these modalities should be stratified in terms of. High-risk patients are patients with first-degree relatives with colon cancer or an advanced adenoma before the age of 60, or 2 first-degree relatives of any age. And it's recommended that individuals with this family history start at age 40 or 10 years before the index case. And then there is a moderate risk group that's a fairly large group in which 1 first-degree relative with colon cancer at any age, age 60 or above, or 2 second-degree relatives with colon cancer. And these are recommended to start at age 40 and be colonoscoped every 10 years. Of course, that would be if they're free of any polyps. What are our current guidelines? The group on the left, the Multi-Society Task Force on Colorectal Cancer, got together with the American Cancer Society and the American College of Radiology, and they came forth with a set of guidelines that stratifies what is the best way to screen for colon cancer. And they actually included in Tier 1 colonoscopy and fecal occult blood testing in the form of FIT. The old FOBT, by the way, is not recommended anymore. Tier 2 was CT colonography, Cologuard, and sigmoidoscopy. And Tier 3 was capsule colonoscopy. The U.S. Preventive Task Force said, we don't care so much about what you do as long as you do it. Do one of these things. Get involved in a screening program, and they don't make any preferences. And the American College of Gastroenterology separates these groups into 2, which is preventive and cancer detection. And they placed colonoscopy, fecal blood testing, and flexible sigmoidoscopy and CT colonography in the former group, and Cologuard in the latter. And I frankly don't quite understand that, because Cologuard does include FIT, so you might wonder why they consider Cologuard less preferable than FIT. I think that's about the end of the talk. If anybody has any questions for me, I'd be more than happy to answer them.